Hello, what an honor to welcome everyone this afternoon. I'm Sarah Cheney, Executive Director of Shepherd Centers of America, and we are a national network of 55 affiliates in 17 states, connecting nearly 200,000 older adults to life-enriching programs. And our common mission to reduce social isolation is even more vital and more urgent during the current pandemic. We're happy to have everyone join us today, especially those of you who may be learning about our network for the very first time. One of our superstar affiliates is LifeQuest of Arkansas, and we are proud to partner with them to share this presentation today.
Thank you, Sarah. I am Lindy Harrell. I'm an Executive Director of LifeQuest of Arkansas, which began about 40 years ago as Shepherd Center of Little Rock. We are proud to be part of this national organization, and we're happy to partner with them today, presenting an important and timely presentation. Leah Greenfield is here to join us to introduce our guest and speaker. Leah, are you there?
I'm here. I'm so glad to be with everyone today. As Sarah mentioned, I don't know if y'all know, but Sarah is presenting as Executive Director from Shepherd Center of America from her office, and we have affiliate groups from all over the United States tuning in to hear our guest speaker who has just joined us, Dr. Joe Smizer. Welcome. I'm so glad to see you. I'm Leah. I'm the Program Director for LifeQuest of Arkansas, but we're partnering with Shepherd Centers from all over the United States. And what a week, right? I don't know. Has anything really much been going on the past week about COVID-19 vaccines, or anything in the news lately about Facebook or Twitter on topics such as vaccines? It's been a wild month, hasn't it? Wild year.
It still feels like it's 2020.
I know that you have a very busy schedule, but I want to give you a brief introduction, if that's okay.
Sure.
Because I want everybody to know who you are and why we have invited you and your organization to be with us today. We are groups of centers from all over the United States, but our members are older adults, mostly in their 70s, but we have members ranging from 50 to 100. And these are groups that have been particularly vulnerable during this pandemic, and they are particularly interested in this vaccine, and they're getting vaccinated in droves. But our topic today is the COVID-19 vaccine, understanding the role of social media, messaging, and misinformation. And so that is particularly new information for most of us, and particularly for our groups that we work with. You are a nationally recognized leader in public health communications. And for those of you who don't know, he holds a master's and PhD in public health and did his doctoral training at the CDC. Is that where you are today?
No, I'm in DC, and I'm now the CEO of the public health nonprofit, Public Good Projects.
Okay, so the Public Good Projects, that is a nonprofit, public health nonprofit, specializing in, and I'm going to read, large-scale media monitoring programs. You're going to have to tell us what all this means exactly. Social and behavioral change interventions and cross-sector initiatives. Basically, what I read and what I understood is that you're working to stop the spread of misinformation on public health issues by advocating for facts, science, and vaccines. Dr. Smizer and the Public Good Projects have designed some of the United States' most influential and large-scale impactful health campaigns ever created. They are in partnership with the CDC, the FDA, Kaiser Permanente, Rockefeller, Humana, and even UNICEF. So you really are global at this point in your scope. Well, thank you so much. I know it's been a busy week. We've mentioned that. I want to hear from you. We have your PowerPoint ready. We're on standby to pull that up whenever you direct us to. So I will let you take it away from here. Thank you.
Thanks, Leah, and thanks again for having me here today. And I want to start by saying I don't really view 70 or 80 years old as all that old. all my bosses are in their 70s and 80s. Most of our board members are retired executives, retired professionals, or currently still working, either professionally or as a researcher in academia. So I just want to thank you all for tuning in today. I know you're busy too, and you have other things you could be doing with your time. So I just appreciate you spending it with me. And this is a nice change for me, because I'm normally talking about a particular program of ours, or reporting on results, or talking to a reporter to help them write a story about misinformation or vaccine hesitancy. I don't often get to just take a step back and talk about my organization and what it is that I do personally. So this is a nice break, and I've been looking forward to it. Even with all the madness going on around the Johnson & Johnson announcement, and just everything that we're seeing in the news every day, it feels like. I did come with a presentation, but I didn't want to necessarily have to go slide by slide. I wanted to make sure that we had some time just for a conversation. I know that many of you are probably just like me, glued to your television sets and your news feeds, and you're trying your best to keep track of everything that's going on. So for as much as I can, I'd be happy to answer any questions that you have, to have a dialogue today. I know that we don't have all the time in the world, but I wanted to offer that rather than go through a more formal presentation. So if it works for you all, I thought what we might do today is I could take you through with just a few slides, give you a better sense of what it is that PGP does, and then we could stop that part right there, and we could then go into a bit of a conversation. So we can go ahead and start that way, and then I promise it won't take the whole time. It won't be death by PowerPoint, and then we can jump into a conversation. And I think I'm seeing I'm not seeing the presentation view. I think I'm seeing all the slides on the side. So if there's a way to just give us 1 second. This is my first time presenting here. Sorry about the hold. And Leah, are you the one advancing the slides?
I am trying to pull up your presentation mode. It's not wanting to share the presentation mode. I tell you what, I'm going to go on and pull up the slides that you saw, and I'll keep working on the back end.
If it's helpful, it says that I can share my screen, which I'm happy to do. I don't know
yes, go ahead and do that. Okay. Yeah, go on and see if it'll work on your end.
Let's do it. It's funny, we're all so used to doing this every day, and I feel like every presentation I give, no matter how much I prepare, it never goes exactly according to plan.
We've been doing this a year, and we totally agree. We understand.
All right, let's see if this works.
All right.
Okay.
All right, here it comes up. Let me share. Oh, you're good. Okay, take off with it. Thank you.
Okay, great. Well, so you all have heard my name, and you can just call me Joe. That's what I go by. And I've been at PGP, or the Public Good Projects, for about 5 years now. We work on a lot of different public health topics. So some of them you can see here on the slide. I know that some organizations are specialists, and they work in, for example, they're just working on the opioid epidemic, or they're just working on vaccines. We function kind of like a health department. So we're not a huge organization. We're about 50 people. And most of those people are public health professionals. And just like a health department, whatever topic is in front of us, we just use the tools of public health, just good old-fashioned epidemiology and health communications. And we work with some other staff who are experts in data science, or engineering, or media. So we work in cross teams just like that, and we tackle whatever issue we're asked to tackle, usually working with a state health department We work with CDC and other HHS agencies at the federal level. And then you heard some of our other partners and funders a little bit earlier, like large health systems like Kaiser Permanente, Trinity Health, or Dignity Health. Internationally, we work with UNICEF, and we are also assisting the Canadian government in the rollout of its vaccines. So we do a lot. Those 50 people I mentioned do a lot every day. But it's really interesting work. It's really fun work. How we do it is in a real simple way is right here on this slide. So we work on a collective impact model. I'll explain what that means. We use social media influencers, and I'll give you a bit more detail about how that works. Everything is evaluated scientifically. So what that means is we evaluate the effectiveness of our programs, of our interventions, exactly the same way the CDC does, or the FDA, or other public health institutions. And I'll share a little bit about the results from some of that work as well. I wasn't going to go too deep into the media monitoring. I was going to save that for the conversation portion of our talk today. So if you're particularly interested in that, don't worry, we'll touch on it. So the PowerPoint focuses on these three areas today. So for collective impact, I didn't make up that term. This is what collective impact means. It's interesting because outside of the United States, like in global health or international health, collective impact is a really common model. It's a model of community health. It's how USAID or UN agencies work every day. And the gist of it is there's one organization who organizes other organizations so that they're all working with common purpose. They're all using the same measure of success. They all know what success looks like. They all agree on that. And then everything that they do, all of the programs of all of those organizations are working in concert. They're all working to the same end. When PGP uses this model, we are often functioning as the backbone organization. So we're the ones that reach out to all the other organizations, explain what we're doing, build those relationships, and then work with those organizations over a long period of time to gradually create public health outcomes in whatever geography we're working in. Might be a state, might be a country, sometimes it's just a county. This is an example of how that works. This is a intervention that is currently running right now in the state of Pennsylvania. And it's focused on the opioid epidemic. The reason I put this in here is if you've been following the news today, you've seen that the CDC just announced that we have backslid as a country so far on opioid overdoses that we are in a worse place today than we were at the height, at the peak of the opioid crisis. So all of that news that we've all seen about the opioid crisis and the announcements from different White House, different federal administrations, all the data that we've been seeing from CDC, we're now worse off today than we ever have been. And that was really tragic news to receive on a Tuesday, excuse me, on a Wednesday. But we have a way that we've been working with Pennsylvania, and it seems to be making some good progress. So I thought I would share it because it kind of explains how we do the rest of our work. You can look up this campaign. It's Life Unites Us. There's a website, so you can check it out if you're interested. But really, what we're doing here is we're focusing on stigma, the stigma of what's called opioid use disorder, and all that means is somebody who's addicted to opioids, somebody who's living with addiction. There's a lot of stigma around that the public directs toward that person who's living with addiction. And the serious research that's been done on addiction and on opioid addiction in particular shows really definitively that if you don't address stigma, you're never going to address anything else. Stigma is directly related to how easily people access treatment, how easily people access recovery, stay in recovery, and then go on to be productive members of society. your friends, neighbors, coworkers, your loved ones. So that's where we chose to focus our effort. We're doing this in partnership with the State Health Department and the Governor of Pennsylvania, along with Penn State, and another nonprofit called Shatterproof. Shatterproof is really the national leader when it comes to addressing addiction. And you can see here who the main people are in each of those organizations. So collective impact, like I mentioned, means working with a lot of different groups. Here are some of the groups that we work with. There are more, but this is a good cross-section. So these are treatment and recovery centers across the state of Pennsylvania, as well as community organizations that in some way are addressing or are fighting on behalf of their communities against the opioid crisis. We work with all of these in a number of ways. And by doing that, we've achieved a significant measure of success in only 6 months of this intervention being active in communities across the state. If you think about this manner of doing this kind of work, as opposed to, for example, a media campaign or a marketing or advertising campaign, there's a really big difference between the two, and really that difference is actual partnership with actual community organizations who are on the front lines of things, know how communities work, know people by name, rather than your usual means of kind of helicoptering in and with fancy television commercials. So this is an example of like every effort, we use social media, but the real crux of the whole effort is stories from people themselves. So there are well over 150 people, and we get more every day, that share how they have been impacted by the opioid crisis, their stories of addiction, their stories of recovery, friends and loved ones sharing their stories of how they've been an ally, how they've helped somebody, things that they've learned. And it's just people talking directly into the camera in a really raw, very real way. And those stories are, there's no magic sauce to these kinds of efforts. It's partnerships and communities, and it's real people talking in a real way. We don't make fancy television commercials. There's a lot of them. Like I mentioned, there's over 150 of these stories right now that are out there across the state. Some of the people, these are real people. No one's paid to participate. Everybody just is stepping up, trying to help out their community. And how that collective impact model really works is we use what you would expect. We use techniques of PR and websites and social media. We do use social media influencers as well. But the most important part, the part that really drives the whole thing, are those community-based organizations. And that's what the CBO at the bottom means, community-based organization. And they send people to us, and we send those stories back to them, and they share those stories with the people that they reach every day, with their neighborhoods and their communities. And so the reach of this kind of effort is far greater than you would get using, what I would call traditional advertising approaches, billboards, signs on buses, radio ads, that sort of stuff. It's not that stuff isn't important, but that stuff is expensive. And usually in public health, we don't have that kind of money to be putting messages in front of people week after week, month after month, year after year, the way that you really need to gradually shift how people see an issue, answer people's questions, give people the information that they need to make informed decisions. So again, that's really the crux right there is the community organizations. And put your money where your mouth is, right? So what we just got results back from our 6 months. So we took a representative sample of the state of Pennsylvania. So we asked enough people that we could say the results from our survey are statistically significant. And what you're looking at here is the purple is people who were exposed to the campaign, to those stories, to those messages, those public health messages. And the pink on the right are the people who weren't. And I think the results speak for themselves. What you're looking at is understanding and agreement with these public health messages, these public health priority facts, and it's been startling. Just really amazing results in a really short amount of time. You have these slides, so I won't read you every single one here. But if you're just casually looking through, I think you'll see the same thing that I do. That if it turns out, if you really partner with communities, you don't helicopter in, and you really just put one person in front of another person, and you emphasize the shared humanity between those two people, that creates real change. It doesn't need to be more complicated than that. Pivoting a bit, talking about influencers. I know social media influencers are a pretty new thing, and a lot of people are still figuring out, what does this mean? There's good stuff and there's bad stuff about it. I think a lot of the time we hear bad stuff. We work with a lot of influencers, and I think a helpful way to think about influencers is they're just people. I think using the term social media influencer makes it seem more confusing than it really needs to be. These are just people who have a social media account and for whatever reason have a little bit more influence, a little bit more reach when they say stuff on social media than your average everyday person. So none of these folks that I'm going to show you today are celebrities. None of them are super famous people. How we talk to social media influencers, how we use them in our work is in the city that they live in, they have a little bit more influence with the people we're trying to reach than somebody else. That's all that this means. And you can see we've worked with influencers on a whole bunch of topics on the slide here, including vaccine hesitancy and COVID-19 communications, everything related to the pandemic. And right now we're working probably with about 1,000 people all over the country. We have a flu campaign that just wrapped up. It was active in these states and DC that you see here at the top of the slide. We're focusing on reaching communities of color in particular for a lot of really important reasons, often really legitimate reasons to be hesitant about vaccines in the healthcare system, extremely legitimate reasons, legacy of malpractice and mistreatment. And then also just the simple idea that people often appreciate hearing facts and figures from people that understand their lived experience, have similar backgrounds, just like everybody. So this uses I think we got up to about 150 people. In this case, we incentivize them the same way you'd be incentivized if you sat through a focus group, for example. At most, we're paying somebody about $90, and that's they'll post on the campaign's behalf a bunch of times. So we're not talking hundreds or thousands of dollars. It's really just paying somebody for their time, which we think is important. And 94% of people who see what these people say something good. And if you have ever looked at the social media accounts, the comments on your state or local health department, on their social media accounts when they're talking about COVID-19 vaccines or flu vaccines, that is not the case. It is almost all negative, and it's a lot of anti-vaxxers, it's a lot of conspiracy theories, it's a lot of myths, it's a lot of nonsense. And that is not the case when average everyday people go out there and just share facts. It turns out that when you do that, when you empower real people, you give them a fact and you let them say it in whatever way that they want to, in a way that they are still speaking authentically. The people who know them and pay attention to them really respect that, and they like it. I won't go too much into detail here. This slide was just really showing that we do make sure that what people say is accurate, and that's really our role here. And then just some examples. These are real people. I know that the font is small, but again, you'll have this, so you can zoom in a little bit later. No, nothing super complicated. It's just people explaining why they're going to get the flu shot, why they trust the flu shot, just basic stuff. Some examples of the comments that these people receive. And then we evaluate this using the same way CDC evaluates flu interventions. And what we found here was the same thing that we found in the opioid stigma campaign. If you put real people in front of other real people and you give them a fact, so you know what they're saying is true and they know what they're saying is true, and they're doing it in an authentic, real way that doesn't strip away their humanity, doesn't feel like a public health official talking, good stuff comes from it. So I'm, of course, simplifying how all this works, but that's really in the middle of it all, is partnership and authenticity. Talking in simple ways that people actually understand. And then just for COVID-19, and this will be the end of the presentation today. A similar deal, reaching communities of color. I think we're about to 200 people by now. Reaching about 200 people reaches about 10 million people. And that last example I gave you for flu, that's about 150 people reaching about 9 million people. So there is real impact when you work with folks like this. And again, none of them are famous. These are just people who have a little bit more reach when they say stuff than your average person. And then none of them are health experts. They're just real everyday people. Auto mechanics, stay-at-home moms, chefs, barbers, all kinds of people. This is in English and Spanish, just some examples of the websites here. Those are some of the people that are working on behalf of the campaign at the moment. Those are some of their posts, and just some examples of what it looks like when they say stuff. And you can see here, it's not overly complicated. It's not a dense, public health official's message. There's a time and a place for that, but I think we could all agree that part of the problem that we've all had for the last year or so is it is very hard to understand where truth lies. And so that's the goal here, is just put somebody up there who doesn't have to have a PhD or an MD, but what they're saying is true. And there's humanity behind it. There's a link there. You understand why they're saying what they're saying, and they look relatable. There's another a woman that's worked with us, and a family. So I'm going to stop there, and then I am very happy to go into a deeper conversation about misinformation, because we're certainly heavily in that space. I could answer questions about what we're seeing, narratives that we're seeing spreading around, what's different now than it was a year ago. There's a whole host of complicated things that are going on, but I didn't want to assume what you all would be interested in. So if you have questions, I'm not sure how it works, but okay, we got a question from Albert. What are the best locations to get reliable information other than the CDC and the NIH? And if there are considered some of these best locations, why do many people feel the government is not a reliable source for correct information regarding the coronavirus? How can these government agencies partner with communities to find influencers or influential community members? I would say that state and local health departments tend to be good places for health information. The problem there is they're on the front lines and they're overworked and understaffed. So they often are not as fast as they would like to be in answering questions from the public and updating their materials. For example, I'd be willing to bet that a lot of state and local health departments don't yet have guidance up relating to the pausing of the Johnson & Johnson vaccine yesterday. They probably have people working on it, but a lot of times they just have one person in a state health department who's in charge of communicating to the public. And that one person does everything. They communicate about everything a public health department has to communicate about. Water quality, restaurant food inspections, they do it all. And so, when the pandemic started, the public health workforce had a workforce shortage of over 50,000 positions. There weren't enough trained professionals to fill 50,000 positions in the United States. That's what it was like going into the pandemic. And during the pandemic, we've had a lot of people burn out. So we've had a lot of people quit, or retire or be forced out because they were used as scapegoats by elected officials. To be frank, so you had a county health director talking about guidance to get through the pandemic, and they were visible, and then they were removed because something that they said upset the community, which that anger is understandable. But there's been a lot of using public health as a punching bag over the last year. So in addition to your websites from your state and local health departments and CDC and NIH, I would say there are good media outlets that give good information. I realize there's challenges there, definitely challenges there. But I would say also it's a huge problem. I don't want to make it out like there actually is a good solution, and there is a fantastic infrastructure providing health information in the United States. That is not the case. I think one of the things that the pandemic has exposed is that outside of the CDC and under-resourced state and local health department pages and news outlets, which often have no source of local information, normally they're just covering national information. We don't have a good source of health information. If you're just trying to figure out what's going on right now where you live, it can be really, really hard. And there's something in the US called a news desert, which is there are hundreds of counties in the United States that have no source of local news, and a local health department that, again, maybe has one person. So it's a big challenge, and I think it's one of the things that it's one of the I hope it's a silver lining that comes out of this, is that we recognize that the public needs information to make choices. And you can't just direct everybody to the CDC's website. The CDC's website is designed for everyone, which means it resonates with almost no one. It's not designed to give you more information than you need. It doesn't go into a lot of detail. It's dense. It's hard to navigate. Anybody at the CDC would admit this. So it's a real challenge, and I wish I had a better answer. But I think part of the answer is a lot of people who were never communicating about health now are, and I hope that's one of the good things that comes out of it. Is it's not just the business of public health to get out there in front of a camera or write an update. There's actually a lot of other people, including community organizations, who might do that better and are just as skilled or more skilled than a health communication specialist at the CDC. As different groups get vaccinated, when does the impact of the pandemic begin to lessen in a way that everyone begins to reap benefits? Well, so there's different theories about what we would need to reach herd immunity. I've seen 70% of the population, and I've seen 85%. Somewhere between there is at the moment where most people in public health feel we need to be. If you look at surveys of the American public and who says that they are interested in getting vaccinated, the most promising surveys that I've seen are around 60% of Americans being willing. So that leaves us with a gap, and a pretty big gap if you think of the hundreds of millions of people in the United States. 10%, 20%, 30% of us is a lot of people, and that's a lot of pockets that are not immune, where variants will be circulating and then reinfecting other communities. So it's a real problem, and there are a lot of people working on it, but I will be the first to say that more needs to be done. And one of the things that does need to be done is a earnest effort to go back to a federalized system in the United States where states and localities have a lot of authority, and the federal government is working in partnership with them and resourcing them in the manner that they need to be resourced. We ask a lot of cities in the United States, and those cities often don't have the resources that they need to do what they know needs to be done. So that's one of the things I hope to come out of this is, if you think about it, the people who have been doing the contact tracing and the testing and now that are doing that are running the immunization clinics, those are the same people that we're asking to communicate to the public every day. There's not a different group of people. It's the same people. So they're already burnt out and exhausted. And there already weren't enough of them. So the only way we're gonna get through this in a better manner is to get, Lions Club, Rotary Club, Kiwanis, YMCAs, Boy Scouts, Girl Scouts, churches. We need all of the organizations that really used to be the fabric of American society and their role has been diminished significantly in the last couple decades in particular. I also hope to see that those organizations get some lifeblood again, and really their role as backbone institutions in their communities is acknowledged, and they are given resources because no one knows communities better than them. Local churches know their neighborhood and their community way better many times than the local health department does. And so I view my role in public health as listening to what they say that they need and trying to support them, rather than expecting them to support what I am trying to do. But that is a really big shift. That's a sea change in how the U.S. Has structured public health. Our tradition in the United States has been, I am a public health professional, I am telling you something, and now I am just expecting that you listen to me. And that obviously, that very clearly is an antiquated way of viewing how communication works. It clearly doesn't work. But I'm happy to keep answering questions. I hope I'm doing a decent job of answering your questions. How do you combat misinformation on social media? That's the question of the day. I could tell you that we work with almost all of the social media companies. They are very far from perfect, and they were very late to the game in trying to figure out how to tackle this in any kind of meaningful way. So within the last year, all of those companies have hired a number of people to focus on misinformation, and in particular, misinformation about the pandemic and about vaccines. But if you think about, a lot of you have a lot of life experience. A lot of you have worked your whole lives. You've volunteered your whole lives. You have a realistic view of how long it takes to do something completely different, how long it takes to evolve an organization into a different direction, or train a brand new employee how to do something that they've never done before. And now you take that truth and you scale it to the scale of the billions of people that social media reaches. It feels overwhelming. It feels like an overwhelming problem. I choose to believe that it isn't. There's some really good scientific ways that we have at identifying misinformation and stopping it before it spreads further. But there is a rift right now between the science that tells us how to do this and the will to do it. And there needs to be a bridge between those two things. So it is not that we do not know how to do it. We do know how to do it. There are other factors at play that are preventing us, some of them very legitimate and some of them utter nonsense, that are preventing us from really tackling misinformation in the way that it needs to be tackled. And part of it is it's so new. Is the recognition that it's a problem is so fresh. Not very much happens at a scale like this in less than a year. Next question: is there much research in the domain of vaccine hesitancy and the role of social media and/or community organizations in the older adult population as a group? No, there isn't. This one's an easy one for me to answer. Should there be? 100%. It's nuts that there isn't. But one of the things that I've seen in my career is there is a strange thing that happens in the United States in particular when an individual turns 65 years old. Suddenly, everyone who's 65 years old or older is viewed by everybody else who's younger than that as the same person. And it makes no sense, and it's complete nonsense. Any marketer or advertiser spends a lot of time trying to segment audiences, to deeply understand. No one would say all mothers are the same, or all fathers are the same, or all Black people are the same. We all know that, and to say otherwise would be nuts. You'd be laughed out of the room. But I see a lot of interventions or communication attempts or research done with and on older adults in the United States. And older adults are presented as a homogenous group that have an identical worldview, identical likes and dislikes. And it's crazy. It makes absolutely no sense. People don't stop being individuals because they turn 65 years old. So that's one thing that I've been talking about. What I hope will come out of the pandemic. That's one thing that I hope will come out of it, is just we put a stop to this utter ridiculous nonsense around not acknowledging that your life doesn't end at the age of 65 years old, and neither does your interest in your individualism. And I think that's part of what is driving the lack of research and the lack of understanding about the dynamics of older adults in the United States, the impact of misinformation on older adults. We have seen it in the response to the pandemic. In many ways, the incredibly shameful way that older adults have been treated during this pandemic. That view that we have as a society, it permeates other things too, and it permeates the study of misinformation. That's one of the things that's been impacted by it. So, and I think that's one of the reasons we haven't really addressed in a serious manner social isolation and loneliness, which is a completely understandable byproduct of aging in the United States. We pretend like it's some mystery why this happens. But I really do hope. Like I said, I've used the word hope a lot during my talk with you today. But I earnestly hope that that's one of the things that comes out of this and I understand why it hasn't happened yet. A little bit. None of us feel like we've even had a chance to breathe. The enormous death toll from the pandemic. So many people have lost friends and loved ones. I myself have. We haven't had a chance to just take a step back and just process what we've all lived through yet. So I hope that when we all get vaccinated and there's some herd immunity and we can walk around and rejoin daily life and enjoy living again and walk around in our communities without being so scared all the time for ourselves or others. I hope that's one of the things that we really seriously address as a country. And I hope I get to be part of it. Well, I can tell by my host coming back in that I'm at my time, but
we do have a follow-up question. But before we get to that, when you were talking about older adults and how we tend to on the media and just to lump them all together, I could feel the nods from around the country about our Shepherd Center group. I could feel the heads nodding, and I was reminded we had a class at LifeQuest on fake news. And the participants of that class, 65 and up, the social media, Facebook intricacies may have been new to some, but this was not an easy group to fool. Yeah. This was a discerning group of people. This was not their first rodeo, and they had a critical eye of what they were looking at. So I just know that I appreciate what you were saying because we love working with this group. We do have a follow-up question though, probably time for one more, and this is from Amy Rossi. How are you funded, and how do you pick what you work on? You had such a scope of projects.
Oh yeah. We get funding, so we don't get funding from the government. That's not because I don't trust the government. It's just that's how we're modeled, and the reason for that is we often help groups like the CDC build out programs, and so we don't want to be viewed as a vendor. We don't want to be viewed as somebody who's just trying to get money from the CDC.
I see. Yeah.
So we get how we get funded is our big foundations. So foundations that fund public health, Rockefeller, Robert Wood Johnson, those usual kind of suspects. Large hospital systems like Kaiser Permanente. And then we've also gotten money from health insurance providers that do a lot of public health work, like Humana. So that's where we get our funding.
Okay, and your projects come from the need, I imagine.
Yeah, it's really driven by need. That's a big part of it. Occasionally it will be someone else has recognized a need. Like a state health department or a big health system will say, we are seeing in our data that there is a huge problem around mental health. And they'll come to us and they'll say, we need to build out a program. We don't have the expertise internally to do it. Can you partner with us and help us make it? So that also happens.
Well, it seems from what you've told us today that you have really struck on a model that is simple and effective. I mean, what I heard, the thing that I will leave here remembering is the person to a person, normal people sharing their stories. And, 6 months ago, personally, I didn't know anybody. I remember saying, do you even know anybody who's had COVID?
Yeah.
And then the tsunami hit.
Yep.
And now who don't we know that hasn't been affected by this?
Yeah.
And then in other communities, the other projects that you're working on, opioid crisis and others. So that human to human connection is just, that makes so much sense. It's almost like, why didn't we think of this before?
Yeah, right. Yeah. What I would say, if I had to sum up the whole approach, it's that the messenger is just as important as the message. And I think that's really easy to forget if you're a technical subject matter expert. You can forget that I am not always the best spokesperson for what we're talking about. In fact, most of the time, I'm probably not.
Well, we're glad to have you here today. And, similarly, 6 months ago, I had not heard of the public good projects, but I bet I'm going to start hearing about them everywhere. You know how that happens.
Thank you.
I bet when we start reading and paying more attention, I bet we're all going to start hearing about Dr. Joe and the public good projects. And we're better for it. We're very fortunate to have you here with us today and in a crazy week and a crazy time. So thank you so much. Yes, you answered our questions. I know it sort of feels like speaking to the void, but we are tuning in from all over the United States today from LifeQuest and Shepherd Center of America. And we thank you very much.
Thank you for having me.